to the ACR Bulletin Podcast, the show where we examine the latest trends affecting radiology. I'm your host, Chris Hobson, and today I'm joined by Chris Treml. Chris serves as Director of the American College of Radiology's Data Science Institute, or DSI. The DSI empowers the advancement, validation, and implementation of artificial intelligence in medical imaging for improved patient care. Chris, it's a pleasure speaking with you today.
Yeah, thanks for having me today, fellow Chris.
Absolutely. Yeah, you're the first Chris we've had on here, I think. That's great. Well, we'll try not to let that trip us up. Today, we'll be focusing on artificial intelligence, or AI, and something called AI Central, which is a tool developed by you all there at the ACR DSI to provide easy to access detailed information regarding FDA cleared AI medical products that are related to radiology and other other imaging domains. But before we delve too far into AI Central, I was hoping you could give us some background as to what the DSI is and the purpose it serves.
Sure. So the DSI was created by the board of the ACR about 5 years ago now. I've been on here for about 4 years as director. Really, the reason why DSI came about is that all of this hype, news going about how AI is going to change healthcare, right? How it's going to play out with it, and there's a lot of truth to that. But what ends up happening is there's only two ways you can really take it. You can either say we're going to get involved with this and try to get ahead and try to make sure that we're helping craft the change so the profession moves with it, and then we're providing better patient care and to be applied correctly. Or you can kind of bury your head in the sand and say hopefully that this just washes over us and doesn't affect us. ACR decided to go with the first route. So that's really what our goal is. We want to try and combine the strengths of our members, the subspecialty expertise that our members have about patient care and medical imaging, and then use our status with the ACR as an honest broker to help bring the industry and the regulatory bodies in to actually make sure that what's being done is providing and advancing safe and effective patient care.
Excellent. Well, thank you so much for that context. I think it'll really help inform the discussion. Now, turning to AI Central, can you please explain a little more detail what that is and how it can help? Like I said off the top, it's a product you all have put out through the DSI. So if you could explain a little more detail what that is and how it can help members in their AI implementation journey, that would be great.
Yeah, it's kind of an interesting story on it because what it is in the end, it's a listing of all the known, at least known by us, medical imaging AI products that are out there. We actually created it because as we're talking with lots of members, other societies, other folks out there as well, we had started compiling a list like this internally, just anecdotally from talking to folks, because you need to kind of get an understanding of it. And so I think it was actually the RSNA in 2018, 2019, that we were like, well, let's just post this online. This is all public information, because then at least when we're out there talking with folks, we can quickly bring up the website for ourselves, even if no one else uses it.
Sure.
And then after we posted up, it actually became very successful, I would argue. We had got lots of inquiries about and built it up. So this last year, we did a big revamping of it, because when we first started, there was 15 products that I think we had on there. And since then, we're now at a listing of about 188, maybe it's 192 now off of there.
Way to jump.
And so we had to really change how it worked to help members be able to do things like, say you're an abdominal radiologist, you're interested in what's in that subspecialty area. So you can filter down on that really quickly and see, here's the 15, 20 odd products in that area. Or you want to know what's available for triage versus CADT or CADX. And so we try to categorize in that way to help members really quickly figure out what it is they care about and what's out there in the marketplace today.
Sure. Well, and we'll go ahead and include a link to AI Central in our show notes, and I'll mention the URL at the end and everything like that, so our audience can explore a little bit more. But before going onto the site, you actually just provided some high level examples there. But I guess if you could provide examples of like what's the most common reason you see maybe for people visiting the site and how they kind of narrow down the range of possible AI solutions, maybe just an operational understanding of how someone could go there.
Yeah, so if you go there, when you first go there, what you see is kind of a listing of everything out there in more of a tabular format. And then there's different search fields and filter fields across the top, similar to what you might be used to, say, in Excel. And then each of the rows is a link that can drill down into specific details about that product off of it. So for instance, you might say something like, I'm a radiologist who's like the abdominal category. And we're talking about maybe doing something specifically with our CT images. We want to just see what's out there off of it, or we're interested in that one. So you can quickly filter down and say subspecialty abdominal, modality is CT, and you can then see all the products that are currently available for that. Then what we do further on that as well is, one of the hard parts that's out there for this is like, just because you've seen a website that says this, or you talk to someone at a conference that said, here's a product we have. So what we try to do as well is we actually pull information out and try to categorize it. This is based on the FDA 510K documents that they have to produce with the FDA that say things like, here's what the actual use is for. So oftentimes they'll say this is only used for triage, or this can be only used as a CADT, it highlights an area behind it. And also get folks to help understand, and this is an area we want to expand over time as that plays with too. Is this meant to be used for all types of patients or only adults? To pediatric patients, is that something that's been tested and verified with it? There's also a lot of stuff too in this area about just how widely validated is this, because it's a huge variation of. What I mean by that is, oftentimes in the clearance we'll see a huge variation of some products won't make any mention of how many radiology cases it was tested on to verify the points. Right. Some will have a very minuscule amount. They'll say, we did this on 100 cases. It looked pretty good. And there are some that said, we've done this on 50,000 cases across 18 different sites and stuff like that. And the reason why I'm trying to call that out too is, one of the hardest parts that we see as members are trying to pick this up in their practice is usually it's trying to understand is, will this actually work for my practice with my demographics, with my protocols and procedures, and go from there, and trying to help folks get an understanding of, how much scrutiny you might need to add an additional that you're not necessarily used to doing for something that's a modality, say, or another type of equipment.
Sure. No, that's a great high level view of that. And I'm wondering, as I guess comprehensive as the site is, something I recently learned is that, although a large number of FDA cleared AI products are actually listed on AI Central, that number actually only represents a portion of the AI products available to radiologists. So I'm wondering if you can explain why that is.
Yeah, I'll try to do my best, because it gets into some of the nuances of what the FDA does and what AI is and how it plays out. So please stop me if I'm saying it that makes just jumbled no sense at all.
Sure, I will do.
Well, the first one off of here is that what we can do today that we can accurately, that we're going after, like, so we're looking at ways to advance in the future, is anything that's been explicitly filed with the FDA. Because if you file with the FDA, typically it's a 510K, or maybe it's a de novo. There's not really many de novo ones out there, but it's a document the FDA said, yes, we validated your claims. Here's proof of it. It's public information. So we go through every month the FDA publishes their new set of products, so to speak, and we go through that and try to figure out what looks like it's medical imaging, what looks like it's AI, and goes from there. And that's how we get to this 180, 192 we're about right now. What that really represents, though, is two things. One is the vendors who are selling that product as an independent product. So for instance, a lot of times where you'll see AI actually being in use today that's kind of subtle is, say, in your packs or in your modality. You bought a new modality and it says maybe it has motion blur detection on it. Odds are that's probably using AI under the hood, but it's not being called as a separate product. So it's just kind of falling underneath that CT machine or underneath your packs and how it plays behind it. So a lot of that stuff's not necessarily included, although there are a few in there where, like, they'll call it as a separate module you can sell, because those just get wrapped up under the hood, so to speak. Another thing that we can only really capture with this is we'll only get what the FDA has under its purview. What I mean by that is FDA says, obviously, if you're diagnosing or you're a therapeutic aspect behind this, and most AI out there today says we're assisting physicians, CAD, right? Computer assisted detection, computer assisted evaluation. So what that ends up meaning is that most AI is not going to fall, or most systems are not going to fall into the FDA's purview, with the exception of if your product interprets pixels. That's something the FDA has explicitly called out. Or if your product looks at pixels to make its output, it's under the FDA's view. So what I mean by that is if a vendor makes a product and they're saying we explicitly look at the pixels in, say, the DICOM study, then it falls in their purview. They need to get 510K clearance for the most part. if they say, we don't look at that, we look at a report and we look at the patient's problem list in the EHR, we look at patient demographics, and we make a output from that, as long as they're not claiming they're making a diagnosis, it's generally not under the FDA's purview. So
Okay.
there's a whole separate area like that as well that's falling out. And that we're seeing that a lot in radiology and like the non-interpretive stages, so things you wouldn't do at your reading workstation, but things around like patient scheduling, around helping out your tech and helping. There's a lot of efficiencies that are going on around billing and areas like that as well.
Yeah, and I on this podcast we talked to Dr. Christoph Wald, and he was talking about AI he uses to triage emergent cases, especially in the overnight hours when you're more short-staffed, or if you happen to be short-staffed, it can act as a second pair of eyes to help you prioritize your work list. Stuff like, is that what the kind of thing you're talking about?
Kind of. That one actually is a little bit different. So most of the triage products out there will actually look at the image itself, and they'll say, based on this image, we believe this is a high priority because
it
might be an internal hemorrhage and so on. So almost all those actually do fall into the purview.
Good to know. Okay.
And actually on the website too, there's a type column we have, and that actually falls into the category of CADT. So it's actually computer assisted detection for triage.
I see. Okay. Yeah, I wasn't sure. Yeah, I'm sorry.
Yeah, I was gonna say one side really interesting on CADT from this that actually I think has thrown the whole not the industry for a loop, but I think really kind of changed the dynamic a little bit from what you might expect from traditional vendors in this area, is because what CADT does is just says, is this possibly a high priority or not?
Right.
The barrier to entry is actually much lower than saying, we think this is truly a diagnosis.
That was what I was wondering, because you have to, as a radiologist, at least in Dr. Wald's case, he would have to still sign off on that.
Yep.
I don't think it's not an automatic recommendation or something.
And even with like a CADX, there's still a physician review aspect behind it. But the way that the FDA kind of rates it is, have you ever seen the autonomous vehicle stuff that the DOT has, where it's like level 1, level 2, level 3, level 4?
I think I have.
It kind of says like as you're moving on up, there's more scrutiny over what it is. All right.
Sure.
And that's kind of what it is. Whereas CADT is kind of at the bottom, even though. So a lot more gets out the door that may or may not be as valid, but from the FDA standpoint, and just from a use case standpoint, right, it has less impact on direct patient care, because their claim is right, and I think it's fair, is we're just prioritizing the work list. We're not telling the radiologist that there's an intracranial hemorrhage or there's a pneumothorax and so on. We're just saying this looks like there's something odd here. Here's a high priority.
Okay. And just to tie that back, that type of technology would appear in AI Central, it sounds like.
Yes, because almost all of those look at the actual pixel to make those decisions.
That makes perfect sense to it. Okay, now thank you for setting me straight on that.
Yeah, and hopefully that all made sense.
It actually really did, and I encourage people to go back and watch Dr. Wald's episode too. It was really interesting. Now, what trend? I guess we've talked about kind of everything leading up to this point. I guess in the here and now, what are some trends you're seeing technology-wise, maybe in radiology, as it compares to other specialties?
So I think probably a big one off to here is radiology across the healthcare world, so to speak. I would argue in terms of AI is really on the bleeding edge. So, we could go into a whole thing about why that is, which we'll probably skip over for today. But essentially, I would argue is radiology is more advanced in this area because there's been a lot more attention on radiology. There's a lot more push in radiology behind it, and now we're starting to see a lot of this stuff hit other specialties. In a variety of ways. And so one of the things that we've been seeing at the DSI, and we've been trying to work through and encourage and provide materials around, is helping set up our members and radiologists to be the experts in their area. Because a lot of the same stuff that was going through radiology, say 3 years ago, is now starting to hit, say, ophthalmology, dermatology, primary care, surgery in these different areas. And so, especially with how interconnected radiology is with all these different spots, really we're seeing is that this is a good opportunity for radiology and radiologists to really be viewed as the expert in organizations around the adoption of this technology, what it means, how to really take it on to, as we were saying before, to really better improve patient care across the board. Really interesting. Okay, well that helps us situate radiology in
spectrum there. Well, I guess now we've talked about leading up to the kind of the moment, but what about the future? Now, where do you see AI going with respect to something like, we could take this in so many different directions, but something pet project of mine, population health management.
Sure.
Maybe we could start there, and if you have any thoughts in any other realms.
Yeah. There's a couple of ways I think it's really important off here. So one is population health management has always come down to is, can you get data? Can you get discrete data? One of the hard parts in radiology has always been due to the time pressures that radiologists are under. It's essentially the ROI on making radiologists generate discrete data. Like, here's a discrete measurement in a way that's not part of your textual report, just hasn't made sense because of how things play out. Like, everyone agrees structured reporting, discrete data is the right thing to do. It's just economically never been very feasible due to the constraints folks are under. So one of the really interesting things there is AI can really help out in that spot by actually doing a lot of that grunt work, so to speak, by generating those aspects. Now, still in the end, the radiologist would have purview over agreeing, rejecting, and playing up from there. But as it happens, now you can start imagining worlds where, say, a chest CT has been performed. And we've been calling this opportunistic quantification, where now you get, say, 5, 6, 7, a couple dozen different measurements off of there. And that can be sent down the report in a discrete manner. So now you, from a population health standpoint, now you have additional data points, just like, say, some of your vitals and labs and so on that you can use. A couple other really interesting areas too with this that I think helps out population health management, especially population management, because it's meant to be at a scalable global level, right?
Right.
Yeah, that is where humans are very, very poor at numbers, right? And that's essentially when we talk about AI, we're really saying data science, hence Data Science Institute. And data science is really saying, how do you analyze and pull correlations and details out of just essentially a huge, big bucket of data, right? Big data, so to speak.
Right.
And so applying some of the different methodologies to, as this data becomes more richer and more higher fidelity and larger, to be able to tease out what are the different types of populations and what does that mean, right? So it was really interesting is like, so today a lot of the stuff we're typically seeing is from well-known, well-studied trends. Things like, I'll use lung cancer screening, for example, right? Where it's like, if you fall into this category of doing these things that are independently verified, that means you should be follow up with lung cancer screening, or you should be a smoking cessation program, or these different aspects.
Right.
But what you could start getting after, I think would be interesting, and we're starting to see some of this happen, where you can use a lot of these data science techniques to start finding new correlations of possibilities. Now, I always call it, the hard part with this is don't assume because the machine did it, it's right. What it's finding is it's finding correlations. It's finding, here's an interesting pattern. These types of patients, when this particular data point's there, has a relationship. You may just be completely coincidental, right? So for instance, one I remember hearing about, just as an example of how you have to be on guard, is possible patients who might develop sepsis during an inpatient stay. One of the highest data points that could help correlate that was marital status. Now, does that actually mean if you're single that somehow there's a higher that actually causes the disease to actually incur more? No, but it's probably a stand-in for other environmental effects and other data points that we don't know, right? Or it could just happen to be that. Or there's another interesting one too of a study that was done to generate an AI model for detecting pneumonia. So a little bit different population health, but essentially what AI did was found the pneumonia patients typically were done on a portable machine. So look at the DICOM study, saw portable as a discrete field, and it basically just said if portable is yes, then it's pneumonia. It just said it, and it had a pretty good rate of success, right?
Oh.
That's where what's really interesting with it is they can take all this data and help you find new correlations, but you still want to do the analysis afterwards to figure out, are these correlations real? And if they are real, what can we extrapolate and do more in-depth aspects on? What's interesting about it is they can do this stuff really, really fast. So we can take all this data and start finding 3, 4, 5 different correlations of what that can mean. Like, will a patient potentially develop diabetes? Will they potentially develop other long-term chronic effects? And break that out to in a way where now humans can start diving into that and start actually better understanding, see what's applicable and what's not, versus throwing humans in right from the very beginning, which is a much longer, drawn-out process.
Right.
Hopefully that all made sense. I kind of went a little
it did.
Maybe a little too in depth on that.
No, I'm glad you skewed to the kind of clinical, because you can also, and you and I talked the other day, so I know you're well familiar with the fact that you can also kind of apply things like predictive analytics or really delving into analytics to help with scheduling things or shoring up miscare opportunities, like predicting which patients might not show up. So really like deploying nurse navigators to help shore up those potential miscare opportunities. I mean, there's all sorts of applications, and it all is under the purview of population health management, as far as I'm concerned. But I'm glad you kept us in the clinical realm there. That's probably most interesting to our audience. So I would think.
I mean, a lot of this stuff is what's interesting about this is, and I'll tell you, and one thing we didn't quite hit on with this one is, so we kind of talked about here's all these new players, and that's a lot of way of an AI-centric making new products. You have a lot of, I'll say the established players, right? And those are the ones who are like putting into your packs, your modality and so on. There's another really interesting field that I think is going to be where a lot of, I think, the high impact innovation is coming from. And that's actually internalizing this at your organization. So it's interesting, and we're seeing this more and more over the last. So at first, 5 years ago, right, it was happening where you thought, where they're setting up their own data science centers, right?
Sure.
It'd be all the normal suspects you'd anticipate, the big R1 institutions that get all the grants and they're trying to make publications. And now we've been slowly seeing that move out of just those to maybe the R2s to now just even the large community or large private practice ones. Because what's interesting about it is that so much of this can be operationalized, but also so much of what we're talking about, like this population health management aspect, right? So much of this is honestly going to be custom to what you're doing at your practice in your ways.
Sure.
And what the technology and techniques can do can help you better understand what you're doing, what your patients are doing, how things are happening at your place. So it's not always so just drop it in another spot and you can use it. And the technology itself is becoming easier and easier to pick up on internalize. So we're seeing lots of folks essentially make internal custom AI or internal custom data centers to best help them out with their own investigations, their own research, and their own operations.
That's so interesting. And Dr. Wald, just to call back to that earlier podcast I keep bringing up, but he was quick to mention that if you don't have the resources to do something like that, that it's perfectly okay to go outside and talk to vendors. And I'm sure, hopefully, I don't know, I don't want to speak for you, but maybe DSI could help facilitate some of that. I don't know if you guys are there yet, or if you have plans to do anything like that, or
well, we always have plans to do a lot of stuff. The line we need to walk, and I'll kind of hit on why we don't have a straight yes on this at this moment.
Sure.
But the line we always want to walk is, we want to support our members and be there for our members first and foremost. So there's always this line of being an honest broker behind it. So we don't. So you have to be a little careful about saying, here's the right vendor for you, or here's what now, what we definitely want to do is help members be able to help navigate that aspect, help them know what questions to ask, what's out there, how to get started, how to protect what you're going after. So for instance, a slightly different one, but I think is a good, a similar pathway was a while ago, a lot of what was questioned, it's still out there, but like, how do I handle data share? So some vendor wants to work with you, they want access to my data. What's the right thing to do there? So what we didn't do is go in and say like, well, you should sell a CT at this much money, because that's what it was. But we did try to do is say like, well, here's the things you need to watch out for and think about. So for instance, we saw sometimes vendors doing things like, slip into the fine print. They're talking to you about how they want to be able to use your data to make a better product for you, to make what you're using better. And then in the fine print, they'll say, oh, also we can use all this data for whatever we want afterwards as well.
Right.
Probably not what you want to be able to do. Or like slide in, oh, we also now own what happened, so we can resell this to whoever we want as well. And so little things like that come off of it. Or, we saw a few cases, now I'm picking all the really bad examples, but just this is why we kind of put this stuff together, where the vendor came in and they talked to the radiology group, and the radiology group saw what they were doing, said, hey, no, these are not good agreements. Like, this is not a good, we're betraying our patients, or we're not following proper procedure here.
Sure.
And do the integrated nation of healthcare that's happening a lot. They went, okay, well, we're going to go talk to the internalists and see if they'll sign off on this, because that's how we get access to it. And little things like that. Now, luckily, a lot of stuff has died down as the industry become more mature. But that's a good line of like what we're thinking about. How do you work up with vendors in the same way? We don't want to be in the position of just being the matchmaker relay between our members and vendors. They should be able to choose the vendors they feel right. But we want to make sure our members are equipped to be able to properly engage with them.
Well, thank you for clarifying that. That was something I didn't know. So I'm learning a lot today. I think our audience will too. So, well, thank you so much, Chris, for this really interesting conversation. I hope you'll come back and periodically update us on all the goings on in technology and radiology. Hopefully you'll be open to doing that.
Yeah, I'm happy anytime. It was really more along the lines of you probably don't want me to come back so often because I'll just keep rambling on and on and on.
Yeah, you'll come at the pace of technology, so we'll have you
Yeah.
weekly now. Well, I guess to that end, till next time when we talk, where can you direct people to for more resources if they want to learn more?
Yeah, the easiest way is acrdsi.org. It has that's all of our online resources are on there, or it's linked off of there as well. It's how you get to like AI Central or other stuff. We have like AI Lab, the e-learning hub on different videos and materials. And then also on there too, if any of our folks listening have any questions or inquiries or want to follow us on there, we also have a contact page that you can use to fill in, and we're happy to talk with folks and members and help address their issues as best kind of their questions.
Excellent. Thank you so much for being there and being so flexible for the members. Well, and for our listeners, if you have any ideas for future show topics, please let us know on Twitter at the handle @RadiologyACR, and please include hashtag ACR Bulletin Podcast in your tweet. We love to hear back from you. And I also invite you all to check out all of our past episodes at Apple Podcasts, Spotify, Google Podcasts, and be sure to subscribe to ACR's YouTube channel. Stay up to date on all of our latest episodes. We have quite a few up there from our past archive. And finally, please hit the like button on this video if you found it valuable. Thanks so much, Chris. We really value your time, and please do come back.
Yeah, thanks for having me today.
Absolutely. This has been the ACR Bulletin Podcast. See you next time.